Hello, and welcome back to The Vitals, the Mount Sinai Health System's groundbreaking roundtable video podcast. I'm your guest host for the episode, Dr. Dennis Charney, a biological psychiatrist and former dean of the Icahn School of Medicine at Mount Sinai. The subject today of ketamine treatment for depression has received a lot of coverage in the media, often without attention paid to the little things, like science or data. So questions pile up. How does ketamine work as an antidepressant? What is the research currently telling us? And what does the next generation of treatment look like? To walk us through all of this, we're joined by doctors Adriana Feder and James Murrough, both professors of psychiatry here at the Mount Sinai Health System, and both at the forefront of research and treatment. Welcome, James, and welcome, Adriana.
Good to be here.
Today we're going to talk about ketamine, which is a treatment for depression. In fact, it's, unquote, the market in which doctors can prescribe ketamine. It's called the Spravato. I want to start by talking about how was ketamine actually discovered as a new treatment, because it's very different than other antidepressant drugs like Prozac and Zoloft, and in a couple of ways. One, ketamine works very fast. It can work in a few hours, and it can work for patients who have not responded effectively with other antidepressant drugs, and we're going to get into that. But first, I want to talk about how it was discovered. And I was one of the discoverers of ketamine with John Crystal, who's now the chair of psychiatry at Yale. But when we made the discovery, it was back in the mid-1990s, so we were a lot younger. And at that point, I was at Yale, and so was John, and we were working together. Now, we had done a lot of work with the traditional antidepressants, like I mentioned, Prozac and Zoloft, and we were unsatisfied with the rate in which those drugs worked and how fast they worked. Traditionally, those drugs take several weeks or, in some cases even months, and they don't work for everybody. And
Right.
Depression is a very serious disease. Some patients are suicidal and even commit suicide. So we wanted to do better. Now, the traditional antidepressants work through a system called monoamines. That's like norepinephrine or adrenaline or the neurochemical serotonin. So we felt we needed to make a discovery that was different than those drugs. So we had done a lot of studies in trying to maximize the effect of the available drugs at that time, and we really couldn't do it. So we thought there might be another chemical system in the brain that might work better than those monoamines. And that system is glutamate, another neurotransmitter in the brain. The drug that came to our mind at that point that affected glutamate was ketamine. Ketamine had been around for decades. It actually was being used as an anesthetic agent. It was also recreationally used and was known as Special K. But we thought maybe it could be an antidepressant. So initially, we did a study when we were at Yale in 7 patients who were depressed. And when we did that work, it was like a miracle. Patients who were depressed in many cases for a very long time, when we gave them ketamine, they got better in a few hours. Now, John and I were experienced clinicians, and even though it was only a small number of patients, we felt this was real, and it was spectacular. So we ended up publishing a small paper in a journal called Biological Psychiatry, and nobody believed it. The field did not believe it. They felt that you couldn't get patients better so quickly, and there was concern about ketamine because it was used recreationally, a Special K. So I left Yale at that point to go to the National Institutes of Mental Health, and they got the group there who were working closely with me Carlos Cerati and Husseini Manji. And we said, okay, let's do another study with ketamine. And we found the same result. And we published that in another journal. And after that second paper, that second study, the field started to believe that actually ketamine might work in seriously depressed people, and it works fast. And so it did change the field. A lot of people said it was the biggest change in the treatment of depression for 50 years. And ultimately, in collaboration with a drug company, Janssen, part of J&J, ketamine was approved by the FDA as a treatment for treatment-resistant depression and is now marketed as Spravato. So that's a brief description of how ketamine came to be, and now it's used all over the world. And I have James Murrough here, Adriana Feder here, who have a lot of experience with using ketamine. So I thought we would start, James, with you.
Yeah.
What's been your clinical experience in using ketamine for treatment-resistant depression?
Yeah. Thanks, Dennis. Also, maybe even before I answer that, I'm thinking back to, during my training in psychiatry, I met Dennis and Adriana. I think after the initial study was done at Yale that Dennis described, and then the second one at the NIMH, then Dennis moved to Mount Sinai, became the dean, and started a new research program. And that was kind of happening as I was training to become a psychiatrist here. And the first order of business was, let's actually replicate it again, right, at Mount Sinai and a few other things. Right. One of the memories I'm having of those sort of early days is when I started working with it, set up the first research studies.
Yeah, but that
was
that's a long time ago now.
This was 2000, mid-2000s. Yeah.
Yeah. 20 years ago.
Yeah, exactly. And even though the first two studies were published, I think the first study had 7 or 8 people. The second one had maybe 20. Single infusion versus placebo, saline. There were still a lot of questions. It was still an uphill battle. A lot of people not convinced, maybe rightly so. And that's science. In those days, we did a lot of things to really further that. And one of the first things we did was ask the question, because one of the questions as a sort of a junior doctor and researcher at the time, I would go to conferences and people knew about the early studies and we were starting to do things at Mount Sinai. And one of the questions I heard was, but you were giving a potent anesthetic to someone with depression and then they're reporting they don't have depression anymore or something to this effect. Could you have given any anesthetic? I remember presenting a poster of the first study, and people that don't remember this, the first study ever to give more than one infusion to a patient as an actual treatment was developed and done at Mount Sinai. Yeah. I remember presenting that data and people saying, how do you know they didn't forget they were depressed because an anesthetic. So,
by the way, though, we had to remind them that the dose of ketamine that we used is way below
that's right.
the anesthetic dose. So
that's
it wasn't working as part of anesthesia.
That's right. But one of the things we did, and now even to this day, set the standard of how do you have a control condition. We used a different anesthetic, and that turned out to be, I think, a major contribution to the field. We used midazolam, Versed, and in what I think of as the third landmark study of ketamine in severe depression, the first one being at Yale, the second one being at NIMH, the third one being at Mount Sinai, this time compared a single dose of ketamine to a different anesthetic, a much higher bar for a placebo. And it was a multi-site study, and it was in about 3 times as many individuals. So that was really exciting. Now, to your question, so now way before the Spravato days,
Well, then we did the first repeated dose study.
So we
started with a single dose, but then
that's right.
We did the repeated doses.
That's right. So we did the first of what we were calling an active control, an active placebo, ketamine versus midazolam, but at the same time, no one had ever at least published on giving more than one infusion. So we looked at, we said, what's another model of a medical treatment for severe depression? We thought ECT, Monday, Wednesday, Friday for at least 2 weeks. So that became and that up till maybe still now, that was known as the Mount Sinai schedule for ketamine, Monday, Wednesday, Friday for 2 weeks. And even before we started using it clinically in those early days of the treatments, yeah, we saw some miracles, I think it's fair to say. Did every single patient, was every patient cured? No.
So that you,
But
can you give us an example?
Well, I was thinking earlier before we started of a case fairly early on. It's often the first one or two that you see stick in your mind. This was a woman. She was in her 50s and had done very well, had recurrent depression, but had been in a depression for, I think, more than 2 or 3 years by the time we saw her in the research clinic. And one of the things we know, depression is one of the most serious medical conditions there are, in part because it's so chronic and there's so much disability. So like we hear so many times, this person had stopped being able to work. She had withdrawn from her family and her life was not at all what she'd wanted. And she'd been struggling for years, came into the research program. And I think these were the days where we were still just doing the single infusion. And I remember after her treatment, so we would have them come back the next day. And that was kind of what we call in clinical research, the primary outcome. What is their depression measure one day after the treatment? And I can still remember also the staff, like the research coordinator and stuff. Woman comes in and is like, you do a double take, kind of looks like a different person, just brighter, wearing makeup, and just describing a feeling of a lifted weight starting around after she went home from the clinic, persisting at least till just that morning, and sitting around, okay, maybe we're on to something here.
Maybe it's real.
Something's going on.
So it all started with a few patients,
right?
And clinicians who were knowledgeable and said, maybe we got a real thing here.
Yeah.
And now ketamine's been used in millions of depressed patients.
Amazing.
Let me jump to Adriana. Now, Adriana has led studies looking at whether ketamine actually can work in post-traumatic stress disorder. It's not approved yet by the FDA for that condition. But Adriana, can you say a little bit about how did you get started in looking at whether ketamine can work in post-traumatic stress disorder, and what were some of the results?
Sure. Also, many years ago, shortly after I had joined your research team, you became interested because of the overlap between depression and PTSD, and they often present together. Patients suffer both from PTSD and depression. You became interested in looking at whether ketamine might also not help with PTSD, and I've always been interested in the topics of trauma and resilience. And in patients, there aren't, even to this date, that many effective and approved treatments for patients with PTSD. There are some that work. Only 2 medications remain FDA-approved for PTSD.
And that's actually incredibly bad.
Yes.
Because PTSD is so serious. It's common. And to have only 2 medicines that actually don't work that well,
Yes,
to offer to those patients.
Yes, and also exposure-based psychotherapies are the standard of treatment. And yet, even for those therapies, half of patients have no response or insufficient response or don't tolerate the treatment. And so I want to say that patients with PTSD experience they cannot move past their experience of trauma. They experience recurrent intrusive thoughts and memories and also nightmares about the trauma. They avoid any triggers, so they have a more restricted life, and also restricted emotionally because they become distant from friends and sometimes family, and they cannot experience the full range of emotions, like positive emotions. And so the first study that I led with you here at Mount Sinai of ketamine for PTSD was with patients with more severe forms of chronic PTSD.
And just to interrupt for a moment, so what was the nature of the PTSD? What was in those patients? What was causing the post-traumatic stress disorder?
So in a lot of these patients had experienced an assault or a sexual assault, and they had persistent symptoms for many years. And others, we had a 9/11 responder who had assisted in the aftermath of the 9/11 attacks on the World Trade Center and kept reliving that experience. And there were some accident survivors, severe accident survivors. And so what we saw, the primary outcome, we were interested, just like the first studies of depression that you, James, and Dennis mentioned, we were initially interested in the rapid response, the acute response. And I think that actually that first single infusion of ketamine study where we looked at the response a day later was the first study that we conducted actually comparing it to the psychoactive placebo midazolam that you had mentioned, James. And it showed a superior response. It was a randomized controlled trial, and it showed a superior response at 24 hours to ketamine compared to midazolam. And we saw a subset of patients, not everyone, but there was a subset of patients who, again, a few hours after, felt a relief, like this blanket weight lifting, and also felt that they could connect more with others after an initial infusion and sometimes a few hours later. And we followed that study at Mount Sinai with a first repeated study of ketamine for PTSD compared to midazolam, repeated infusions. The first study of repeated infusions of ketamine. And we used that same frequency and total number of infusions 3 times a week for 2 consecutive weeks. And that was also supported by the fact that in the first study, the average time to losing the initial response was 2-3 days. And so we thought that we liked that frequency of infusion.
That's actually how we came up with the frequency.
Yeah.
That we found that if you gave a single dose, it worked right away. It was a very strong effect, but it was not like an antibiotic. 24, 48, 72 hours later, some symptoms returned, and that's how we thought, let's give it repeatedly so there's no loss of effect. And so we thought 3 times a week. Now, actually, it's marketed with Spravato as twice a week, and that works very effective.
Where there was, interestingly, in depression, there were studies showing that twice a week works equally well for depression as 3 times a week, potentially. However, in PTSD, it might not be. It might be necessary to give it. That still needs to be studied further, 3 times a week. But with that 3 times a week study, we found a robust, rapid response, and we measured it 2 weeks after the first infusion of 6 infusions. And again, patients on 2/3 of patients in the ketamine group were significantly better compared to only 20% in the midazolam
that's a big
group.
effect. We know in depression, you're very sad. You may even be suicidal. And by the way, we know that ketamine can work for suicidal patients. So we do have a good feeling what's happening to those depressed patients. When a PTSD patient is getting better, what is getting better in those patients?
A range of symptoms are getting better, including those that are unique to PTSD, the nightmares, the intrusive thoughts, and also jumping or being very reactive to certain sounds or triggers that are reminders of trauma. So, for example, I can think of a patient who had been a witness, very close witness of a shooting, and she had described that every time she opened the door, the shooting occurred outdoors, outside a supermarket. And every time she opened her door to go outside, she would feel this intense fear come over her. And so after the first or second infusion, that feeling subsided significantly. She felt she could open the door and walk outside.
So it changed her life. It opened it up.
It did change her life. And we have some patients who stopped during the period of infusions and subsequent weeks after repeated infusions also stopped having nightmares. And I also have an example of a 9/11 survivor who felt very tense and afraid whenever she heard an airplane pass overhead. And that also, she experienced relief from that. That one actually was from a combination that I can talk about later of ketamine with an exposure-based psychotherapy from a pilot study that we conducted. I do want to say that depressed mood or a feeling of not being able to enjoy life or connection with others is also part of PTSD. And so in addition to these decrease in sudden arousal or reactivity, we also see an improvement in feeling connected to others, wanting to go out more, feeling more able to enjoy activities, things like that in patients with PTSD.
Yeah, that's an important topic, and I want to actually get to that now. And that is, what is the role of psychotherapy? Because my own feeling is that most patients need a combination.
Yeah.
If they've been depressed for many years,
Yeah.
It's affected their life, and in a way they need rehabilitation.
Yeah.
And the same is true with PTSD patients. So James, your opinion, and actually I know you're doing a study now looking at a therapy along with giving ketamine.
Yeah, so you're exactly right. I would say the sort of standard recommendations for the treatment, particularly of more chronic or serious forms of depression, is usually the patient will benefit from a combination of medicine and psychotherapy. So in some ways, that's the starting point. It kind of makes sense. And you can think of it from a sort of also biological level of if the drug is helping the brain to start to recover. We know that chronic stress causes dysfunction in the brain, including loss of dendrites and other things in cortex, and it can lead to low called neuroplasticity, even difficulty learning. If you're giving a medicine that can boost that, and it seems like ketamine in particular, from a neurochemical standpoint, that sort of seems to be its hallmark of increasing neuroplasticity. Other drugs like Prozac also do it, but probably to a lesser degree and takes longer. But ketamine does it quickly. That was kind of one of the early biological insights, as you well know, with how is ketamine working in the brain, that by stimulating glutamate, it's driving these sort of proplasticity pathways. And it would stand to reason that if somebody is in a therapeutic environment, then that's going to interact with that plasticity and they can learn more, and whether the learning is sort of unlearning maladaptive habits or unlearning repetitive negative thinking, negative self-talk, the cognitive biases that are part of depression. So they probably interact. That being said, most treatments, including ketamine, most medicines are studied a little bit in a vacuum. So they're not studied together with psychotherapy. So we actually don't have a ton of data or like big comparative studies about what if there's been some of this work, right? What if you compare people with just therapy to just medicine and to both. And there's been some sort of landmark studies done, but
generally not with ketamine, though.
Not with ketamine. I don't think that's been done at all with ketamine. And the marketed form of ketamine, which is S-ketamine, Spravato, as you mentioned before, was certainly done without regard to therapy. Typically in these trials, if a participant that gets enrolled in a study, let's say with ketamine, if they're in regular psychotherapy, they can stay.
Right.
Yep. You're not supposed to start new therapy or stop. That's just controlling baseline, but it's never really been compared. Do people do better? So exactly. So we're doing a study right now at Mount Sinai that we're very excited about. In the context of the sort of rediscovery and interest in psychedelics, one of the thinking with psychedelic medicines, whether it's the classic serotonergic psychedelics like psilocybin or the so-called empathogens like MDMA for trauma, which many people may be aware of, some of those models of treatment, the therapy was really an integral part. Something we came to learn a few years ago is that practitioners in the community were actually using ketamine in a, let's call it, psychedelic-assisted therapy model. So this would mean the patient would come in, they would have chronic depression or PTSD or combination, and they would undergo a treatment with a potent psychoactive drug, but it turns out one that you can actually get and doctors can prescribe off-label is ketamine.
Yes.
Today, a doctor can't prescribe psilocybin today. They just can't get a hold of it, MDMA, but you can legally with ketamine. And come to find out in the last number of years, practitioners of the community started using ketamine to bring about these acute psychedelic-like experiences, dare I say it like that, and material comes up. And we know that material comes up. And even the earliest studies that I was part of at Mount Sinai, patients would describe to us anecdotally, they would have these sometimes profound experiences. Sometimes this was when they're on the drug. And then when they come off the drug, it takes about an hour and they'd tell us about their experience, just anecdotally, right? We're asking about side effects and other things. And they'd say, geez, doc, that was pretty interesting. I felt like I went to the end of the universe and back, or I felt like time stood still. Or some of them would even, I think I was telling you about an example a couple of weeks ago, a patient spontaneously said to me that he had examined some of the problems in his life from a different perspective and came to some solutions. He's telling me this after, and that they were like working. So it wasn't just so.
Part of recovery.
Part of recovery. So we don't know. So a really interesting question is we don't know with ketamine, and maybe it's a similar question with some other sort of potent, rapidly acting treatments that might be making their way down the pike, like psilocybin or MDMA. what's the role of psychotherapy? So we're doing a clinical trial right now. I think it's the first of its kind in people with depression that are treatment seeking. And if they enter the study, they get ketamine, what we call the standard Mount Sinai model. They'll get it 2 or 3 times a week for a few weeks without any specific therapy. Or they get ketamine in the context of this psychedelic-assisted therapy model. And this is a little bit different than just someone seeing their therapist once a week and they're also taking their medicine. That's a standard combination of therapy and medicine that we usually would recommend or prescribe for the treatment of depression. But this is actually meeting with a therapist. The therapist is there during the ketamine experience, during the dosing, and then is working with the material that comes up, often in the immediate 1 to 2 hours after the person has had an experience on ketamine. They're there at the clinic, the clinical setting, calming, muted lighting, that type of thing, music.
And that's such an important study to conduct because, as you said, practitioners in the community are doing.
We were surprised.
this
It
kind
turns
of-
out they were doing it, and this is an intensive, potentially costly intervention. But if it's effective and safe, we want to know about it.
Yes.
So we hope to learn. We hope to know. Ask an empirical question. Our gut is that probably if people get the integrated therapy, that's going to be a good thing. Maybe the effect of ketamine will be enhanced. Maybe it'll last longer. But as good,
It could be life-changing.
yeah. But we need to know the answer. We don't know. We think, but we got to actually get the data. Right.
So if somebody's interested in this trial,
Yes.
people listening to this podcast,
Yes.
how can they find out more about it?
Contact me. Find me on the Mount Sinai website. Send me an email, james.murrough@mssm.edu. The Depression Center has a website, so please go there, and we'd love to hear from you.
So, James, thank you
Yeah.
for that. That's
Yeah.
very important
Yeah.
to look at the role of therapy and the use of ketamine as a combination. Adriana, you're also interested in this topic, and I think what you're doing is also very important. Why don't you describe the work that you've been doing in looking at the treatment with ketamine along with a different kind of psychotherapeutic approach?
I have been looking at ketamine combined with an exposure-based psychotherapy, a brief exposure therapy called written exposure therapy. And to backtrack a bit, I had mentioned earlier that exposure-based psychotherapies are the therapies that have the most evidence base.
I'm sorry to interrupt.
Yeah.
Some of our listeners may not know
Oh,
what exposure means.
no,
So if
that's
you
a
can
good point.
describe that.
So exposure-based psychotherapy is a type of psychotherapy that focuses on the trauma and the memories and feelings and thoughts and also sensations like sounds or smells. And the patient is asked to focus repeatedly on those with the idea that there will be a habituation or a decrease in anxiety and re-experiencing over time. And those have been shown to be quite effective for PTSD, but patients sometimes with more severe forms of PTSD drop out of these therapies because it's hard to sit there with memories of the trauma, or it's not effective for everyone. And one important finding in PTSD is that many patients with PTSD have a decreased ability to extinguish their fear. So their fear extinction learning is compromised in PTSD. And that is thought to potentially be due to disconnection between regions in the brain that are involved in fear extinction and emotion regulation. In fact, PTSD has been called...
Just to
Yep.
elaborate on that, fear extinction means despite dealing with your fear repeatedly, it doesn't diminish.
Yep.
And so extinction means, and we want to promote this, that the more and more as you face your fears, the fears are reduced and you can get on with your life without facing your fear in a way that you're inhibited in your life. And your approach is to enhance the extinguishing of those fears.
That's right.
In combination with ketamine.
That's right. And what we found in a pilot study of looking at the brain in patients with PTSD who received repeated infusions is that in those patients for whom ketamine worked in PTSD, looking at their brains with neuroimaging, we saw that the frontal cortex had better regulation of the amygdala, which is the key initial emotion response region of the brain. And so it seems that when you give repeated infusions to start with, and perhaps add an exposure-based or trauma-focused psychotherapy, that the infusions might prime the brain to improve the connectivity and brain function in these patients with PTSD that might enhance the function of trauma-focused psychotherapy. And we chose this brief psychotherapy called written exposure therapy that consists of 5 sessions, and there's less therapist involvement. It's easier to train therapists. And we just published.
Let me
Yeah,
stop you for
sure.
a moment. Then what is written exposure therapy?
Sure.
Can you describe that
Yeah,
to our
and
listeners?
in written exposure therapy, the first session, the therapist explains the idea of focusing on the memory of the trauma and writing about it. Although initially it might be very scary, it might lead to fear extinction or habituation to the memory or decreased fear over time. And then following that, each of the sessions consists of a brief touching base with the therapist and the patient. And then the patient writes for 30 minutes about the trauma and their memories, vivid memories of the trauma, and also the meaning of the trauma in their life and their impact. And we think that by giving ketamine, and importantly, this is a different model than the one that James spoke about compared to ketamine-assisted psychotherapy. We administered the written exposure therapy sessions on different days from the infusions. And that is because we think that the infusions improve connectivity in the brain, make those circuits involved in emotion regulation work better, and potentially increase the efficacy of the trauma-focused psychotherapy.
So the bottom line is that you're both taking the approach that ketamine is doing certain things. It's improving mood in depressed patients and other symptoms. And in PTSD, ketamine alone diminishes the impact of traumatic memories. But now you're both taking the approach of to enhance that effect with different forms of psychotherapy. And I want our listeners to understand that ketamine can work by itself.
Yeah.
But we think we have ways now here at Mount Sinai to further enhance the effect so their life has more meaning, that it could have long-term positive effects, both in patients with severe depression and in patients with the PTSD. James, I want to go back to you for a second. Feeling suicidal, obviously, is in a sense the worst form of depression.
Yeah.
And you've been interested in looking at the impact of ketamine on suicidal thinking with the hope that it would then prevent suicide. Can you say a little bit about that?
Yeah, absolutely. Yeah. Suicide is a devastating outcome of depression that everybody's trying to prevent. The majority of individuals who die by suicide have a diagnosis of major depression. From my perspective, the treatment, there's lots of ways, and suicide is a crisis in this country, and there's lots of different ways to come at it, social, other things. But from a medical perspective, the rapid treatment of a severe depression is kind of the best, is critical. And so ketamine, on one hand, it's already a great candidate because it's now established to be rapidly effective for depression. From the early studies at Mount Sinai, and I was going to
give Mount Sinai credit.
Okay, I have to say.
Credit is due.
I have to say. So we've been talking a lot about different symptoms of depression, symptoms of PTSD. So for listeners out there, I think there's 9 criteria for depression, and there's a range of symptoms. Sad mood is certainly one, but fatigue, inability to experience pleasure, chronic negative thinking, disrupted sleep, loss of appetite, and suicidal thinking or wanting to die. And there's others. And we were very curious early on which symptoms in depression, let alone PTSD, is ketamine active against. And I was kind of hoping that it would be clear which cluster, because that would be scientifically interesting, because then we'd know which circuits do we go after in the brain, but it turned out it was kind of across the board. So ketamine was looked pan-active in depression.
That's a good thing,
which is good for patients. But even there, consistently, we saw there was a dramatic reduction in suicidal thinking. And in particular, we noted in the early studies, even for people that didn't meet a threshold of what we would consider a sort of clinical remission or response from their depression, often their suicidal thinking went to zero.
So what did you do about that?
What
So
did we do
you
about
observed that.
We observed it, and actually, again, as a young researcher working with you and the team, designed what was the first study specifically to look at reduction in suicide as the primary outcome from depression. And what we did is we invited people that were admitted to Mount Sinai Hospital that could have had depression, bipolar disorder, PTSD, OCD, or anxiety disorder, kind of anything in the mood and anxiety spectrum, not schizophrenia or autism. But if you had a sort of stress-related mood, affective disorder, didn't matter, you could come in if you were admitted for suicidality. And that was the first, a small study. Maybe we had 10 and 10, 12 and 12 published.
And so what did you find?
We find that ketamine was superior to our old friend midazolam at reducing suicidal thinking. And that work's been followed up now multiple times, and it's been very exciting. That finding has really stuck.
Right.
Ketamine seems to have specific activity against suicidality. And if you think, what other medicines in psychiatry have that? Lithium.
Yeah, maybe I was going to say lithium, probably.
And maybe clozapine in psychosis, and now ketamine. So that's very exciting.
You deserve a lot of credit for that study. You were the first, along with the NIMH group,
yeah,
right?
Very similar, right around the same time.
Right around the same time.
Yeah.
And ultimately, the FDA has been convinced of that.
Yeah.
Right?
I think the first label, I think that I'm aware of.
Ketamine is labeled as an effective treatment for suicidality.
For depression with suicidal ideation, that's right.
Yeah. So the message there is that, to those listening, if you're seriously depressed, and if you even have suicidal thinking, or even if, unfortunately, maybe even a plan, there's hope.
Yeah.
We don't like to say, but we often say that suicide is a permanent solution to a temporary problem.
Right.
And here we have a drug, ketamine,
yes,
that can help you get out of that.
That's right.
Right?
Yep.
Let's talk, getting toward the end here, but ketamine does affect the brain. And that's probably, in certain ways, that probably relate to why it works right away and works for serious forms of depression and PTSD. Adriana, you've done some research on the impact of ketamine on different brain circuits. Would you like to review that?
Yes, my research was on PTSD, and we found that in treatment responders, patients with PTSD who feel better after repeated infusions of ketamine, they showed better regulation of emotion regulation and improvement in the function of emotion regulation circuits. The prefrontal cortex had the better ability to tone down the overactivation of the basic emotional response region, the amygdala. And that's why actually we were, as I mentioned before, interested in combining ketamine with a psychotherapy. And we actually found in a preliminary study that was recently published that adding written exposure therapy to repeated infusions of ketamine actually resulted in patients remaining better for several months. For those who responded to the combined treatment, stayed better when we talked to them at the 6-month time point. So that's a very exciting potential for the future.
You haven't proven this yet, but it may have more profound effect on those very same circuits that underlie some of the symptoms of PTSD.
Of PTSD, exactly. And what's needed now is a larger randomized controlled trial where we compare the combination versus the therapy alone or the ketamine alone.
Hashtag NIH.
And James, you've done a lot of work on what ketamine has done to the brain. What are the highlights there?
Yeah. So I'm thinking of the first study we published. So if you do a simple experiment where you take people in a depression and you show them emotionally salient pictures, and in the simplest case, you show pictures of other people and they can be expressing like a sad negative affect or like a happy positive, very consistent finding in depression. You look at a part of the brain, deep in the brain, it's an evolutionarily old part of the brain that was really important for positive affect. The basal ganglia. These regions are do not show normal activation when people look at positive images when you have them in a scanner, right? And ketamine reversed that in 24 hours after treatment. So we imaged a bunch of healthy adults that did not have depression and then individuals with serious depression before treatment. And we saw what we expected to see, which was their brain had an abnormal lack of response to positive salient information in the environment in the form of smiling human faces. And the next day, at a brain level, you couldn't really tell the difference between the depressed brains and the healthy. So this kind of showed that ketamine was doing something within this sort of a complementary critical brain system to the one Adriana's talking about, which supports positive emotion. This is in the basal ganglia. And for those of you aficionados out there, this is also described as the ventral striatum or nucleus accumbens. So that was an early finding, and that's been replicated, that ketamine rapidly increases the ability of the brain to respond to positive stimuli. And I'll just say one other finding from us and others. Adriana mentioned the prefrontal cortex, very important for abstract thinking.
That's the front part of the brain.
Yeah, kind of the newest in the history of humans, and it tends to be relatively offline, relatively in a depression, and we think that maybe that also is related to how in a depression someone's emotions, they feel like they don't have control over it. They have difficulty thinking. They have difficulty planning. These are all things that are critical for the prefrontal cortex. And ketamine now, across a number of studies, one way or another has been shown to bring that prefrontal cortex online more integrated with the rest of the brain. So it's increasing the function of these important prefrontal cortical systems, and at the same time increasing the ability of some of these more basic hedonic or almost instinctual systems in the brain to respond to positive information in their environment. So those are two, I think, important signals that we've been seeing.
Thank you. So we're going to wrap up, but I want to wrap up in this way. We talked a lot about ketamine and how it can work for the most serious forms of depression, including patients who have suicidal thinking, and how it works for serious forms of post-traumatic stress disorder. And so I want to leave you with this, and that is there's hope. And you can get treatment that will help you with your depression. And one place you can get it, and here I'm biased, is here at Mount Sinai, that we are one of the very best places in the world to get treatment for depression using both established, approved treatments like ketamine, but also we're never satisfied. We're always looking to do better, to develop new medicines, looking at combination treatments with psychotherapy. We're never satisfied. So, James, I want to let our audience know again, how can they get in contact to the program that you lead, our depression and anxiety program?
Yeah, find us online. Google Depression and Anxiety Center, Mount Sinai. You'll find us. Look for me. We're embedded. The Depression Anxiety Center is embedded within the Department of Psychiatry, which is a large, amazing department, lots of clinical resources. If people can get their way to the Department of Psychiatry, then they'll be able to find us as well. And to learn more about Mount Sinai's work in treating depression or to book an appointment with a Mount Sinai expert, scan the QR code on your screen or click the link in the description below.
Let me ask you this question. What do you feel that patients with depression and patients with PTSD, what do they get wrong about the nature of their illness and what's the course of their illness? Can they get better?
Yeah, two things spring to mind. One is we see this over and over. When someone is in a depression, it feels like it will never end. And that's like the nature of the beast. And patients will describe it. They have different ways of describing it, feeling like they're down in a hole looking up. But so many times when we're fortunate and gratified when a patient gets out of that episode of depression, they'll say, "Doc, I got to tell you, I thought I was never going to get better." And we hear that again and again. So in some ways, depression is insidious because the disease itself is telling the person they will never get better. And the extension of that is why bother? Why go to the doctor? Why take the pill? So it's not so much they get it wrong, it's just that's what the illness is telling them. And then another thing that we hear a lot, and it's cliche, but it's very common, is it's not like a biological illness because it's depression. It's just how you feel. And whether it's the patient's telling us, my loved one or my family, probably meaning well, is saying, just get over it, right? So we still hear that a lot. And I have to pick up, I have a textbook on the neurobiology of mental illness on my desk and point to the brain and show this is a biological illness. So I think there's still a lot of misunderstanding. Psychiatry is a disorder of brain, and we have medicines and psychotherapies to correct those problems, but there's still a lot of misunderstanding and kind of thinking that depression or other forms of mental illness is a problem with your willpower, right? Things like that. So that's a big misconception that we're trying to combat every day.
Thank you for that explanation. And Adriana?
Yes, I think it's similar for PTSD. There's a lot of stigma. And also sometimes the patient might carry the burden because people don't understand the trauma happened a long time ago. Why didn't you get better? Why aren't you over it or able to move forward? And also patients, individuals who suffer from PTSD, they're very fearful and they live more and more restricted lives and might be fearful of going outside. So we commonly see a level of avoidance of seeking treatment, seeking care. And again, the message of hope that you are conveying, Dennis, it's very important because there are more and more treatments available for these conditions, and it's worth really reaching out and seeking care.
And as clinicians, we never give up.
That's right.
Yep.
Thank you, Adriana. Thank you, James.
Thank you.
Thank you.
That's all for this episode of The Vitals. I'm your guest host, Dr. Dennis Charney. Subscribe to The Vitals and the Mount Sinai Health System's other video podcast programming on YouTube, Apple Podcasts, Spotify, or wherever you get your podcast. To learn more about Mount Sinai's work in treating depression, or to book an appointment with a Mount Sinai expert, scan the QR code on your screen or click the link in the description below. To get in touch with the show or suggest an idea for a future episode, email us at podcasts@mountsinai.org.